Well, imagine being a doctor where every patient is desperate for answers. Tonight, our doctors reveal their most common questions and tell us their answers. Plus, we have your questions as well. At the table for this special national checkup, Danielle Martin, a family physician from Women's College Hospital in Toronto, physician Peter Lynn, our CBC medical contributor, Samir Sinha, geriatrician at Mount Sinai here in Toronto, and Viv Rao, head of cardiovascular surgery at the Peter Munk Centre. Their thoughts in a moment, but first, this quick context. When we go to the doctor, we want answers. Of course, TV can make it all look glamorous. Reality must be so different and so difficult, from the simple to the extreme. Are we okay? Why does this hurt? Am I going to live? Our doctors are trusted to give us the answers as best they can. Some of those questions must be frequent, so tonight we'll try to find out not only what they are, but the answers too. So let's get started. And we'll get started with many of your questions, but first, the most common question each one of you get. Peter Lynn, what's the most frequent question you get?
A lot of things about diet. So a lot of people are saying, should I be buying these gluten-free kind of things because they're bombarded with all these ads? And the key thing is that gluten is a protein coming from wheat and rye and barley. And most of us are fine with it. There's only a very small percentage, 1% of the people, where that gluten will attach to the bowel and the body starts attacking it as if it's a foreigner. And in those people, they have celiac disease, so they have to stay away from gluten. But unfortunately, everybody's sort of caught on to this gluten craze. Now, if you want to cut out the breads and the donuts and things like that, I'm all for that. But don't try and cut out a whole food group of, let's say, wheat products, because you're going to be missing a lot of vitamins and things like that. So majority of us, we don't have to go after that extreme.
All right, Danielle.
I see a lot of people wondering why we're not ordering tests that they have become accustomed to having done on a frequent basis. So classically, Pap tests, for example, which used to be done annually, now we know should only be done for most women every 3 years, or mammograms that used to be done annually that we're now doing every 2 years for women over the age of 50. So as guidelines change, I think it can be really confusing for people. And the most important thing to understand is that screening tests for people who feel perfectly well can be useful, but if we do them too frequently, they can actually cause harm. And so that's a conversation I find myself having frequently in my office. What is the right interval to do this where it is most likely to help you and least likely to cause you harm?
All right, Viv.
It's kind of ironic, as a surgeon, most of the patients, after they leave my office, the last question is, do I really need to have surgery? And
this is before the surgery?
Before the surgery, exactly, after we've had the discussion. And it's funny to me because in my specialty, by the time they actually get to me, a lot of people have come to the conclusion that they need surgery, yet they're deathly afraid of surgery. But in other specialties, for example, lower back pain, the vast majority of patients with lower back pain are treated conservatively, but patients want surgery for their lower back pain. Yet when it comes to cardiac disease, even though surgery has been proven to be a benefit, most patients really question whether or not they need it.
Nothing worse than back pain for some people, no doubt about it. Samir.
I mean, as a geriatrician, a lot of my patients come to me saying, is this a normal part of aging? What's normal, what's abnormal? And I think, that when we think about aging, there are normal things that will happen. Our bones and our muscles will thin as we get older, but osteoporosis is not a normal part of aging. People's memory will slow naturally, but dementia is not a normal part of aging, and things like incontinence. So I think a lot of people are always struggling to say, when is this a problem and when is this normal? And then we work together in terms of how to actually address those symptoms.
Well, it's interesting you mentioned that, because some of our questions tonight relate to some of the things you've just brought up. But let's start with our first question from you, our viewers. And this one, Betty Balser writes, I've had severe pain in my right foot, leg, and now hips for over 2 years. I have a pacemaker. Is this related to the heart problem? Now, Viv, we're not going to throw questions at you looking for incident analysis of particular patients' questions, but you found this one interesting and wanted to take a run at it.
Well, I think what she's relating to is whether or not implants can cause systemic disease. And certainly medical history is littered with examples where certain implants can cause disease. But as a result of that, I think modern day implants have all been tested, and even when they fracture, they don't leak out chemicals that can cause toxic problems. The pacemaker is a good example of that. Apart from causing local irritation in the shoulder where it's implanted, it's very unlikely to cause any other systemic problems.
All right. Next question comes from Saskatchewan, from Heather Goddard. Here it is on video.
Hello, my name is Heather Goddard. I'm calling from Saskatchewan, and I have a question for the geriatric specialist. Is there anything that the elderly can do to improve their balance? Because they seem to be falling quite a bit. Thanks. Bye-bye.
All right, Samira, you know, there's no doubt that one of the major causes of big problems for the elderly is falling. What about this question?
Yeah, no, it's an excellent question. I mean, falling is very common in the elderly. In fact, 1 in 3 older adults in the community will fall in any given year. So it's very common, and it can result in emergency room visits and fractures and those problems. So there's a lot of things we can do to prevent falling. I mean, sometimes it's getting your medications reviewed to make sure there aren't things that are causing one to fall, like a low blood pressure, for example. But the basic exercises that people can do, which is the #1 thing we prescribe, are exercise that focuses on strength and balance training. So these are things that physiotherapists, occupational therapists, or even your local gym, they may have a class that focuses on exercises for seniors, for example, and they really focus on strengthening your balance and also strengthening the muscle strength in your lower legs. And by doing those particular exercises, you can significantly reduce your risk of falling. Tai Chi is another excellent example of something that improves our balance.
You know, it's interesting. You know, we have some patients with low sugar and they might also fall. And we tell our patients when you're getting up in the middle of the night to just sit by the edge of the bed, because most of the blood is sort of pooling in your legs. So when you swing your legs over, the blood goes into your legs, not much is going to your head. So if you rush out of bed quickly, you'll tend to get dizzy and fall. So if you just sit, wait a few seconds, and then get up and then go, that's
And there are a lot of cardiovascular medications that intentionally decrease your vascular tone, so that's a very common finding in elderly patients who are on antihypertensive medications, that they really need to take it easy as they're getting out of bed.
All right, next question. Here it is. It comes from Jean Patterson. What progress is being made on diagnostic tests for mild cognitive impairment or early dementia? Samir, you kind of were talking about this issue earlier in your first answer, but what progress is being made?
Yeah, so I mean, again, a little bit of memory loss or some little minor problems, those things that we call seniors' moments are quite normal when we age. The key thing is that when people are thinking, do I have dementia, do I have memory loss, can I do a blood test, or is there an imaging test, an MRI, for example, that I can do? The answer is there's no single test that can do that. Really, if someone has problems with their memory or their thinking, the first thing is to work with your primary care provider. Tell them you have these issues, because sometimes it can be the side effects of medications. Other times it can be a low vitamin level, like a low vitamin B12 level, for example. There can be other things that can cause that. Depression. And then after that, once we actually determine that, no, it looks like there is some significant memory loss, we do cognitive testing, so things like the mini mental status examination, things where we actually get you to draw pictures and answer questions. And once we understand that, mild cognitive impairment are serious memory and thinking problems that don't interfere with your functioning, like taking your meds or doing other things. Dementia is when those cognitive problems actually cause interference with you to do your basic living tasks.
And primary care providers, family doctors are trained to administer those tests, and we know how to do those evaluations. So people don't need to worry about having necessarily access to a specialist to do that. This is the kind of thing that you can go and see your primary care provider, and we know what to do in that circumstance.
Are people shy about even bringing it up?
You know, often, I don't know what Peter's experience has been, but often it's family members who will come in first to express concern about a loved one. And I see a wide variety. Sometimes people are really open to the possibility that they might be having difficulty with their memory. Sometimes that's a really hard thing to come to terms with. And sometimes it's hard to recognize because of the illness. And so there's a wide range.
There's a quick screen that you can do, which is just ask them 3 things. So tell them ball, cat, tree, have them repeat that back to you. And then you ask them to do a little clock. So show me 10 after 11 and get them to draw the clock. So it's amazing how when your memory starts to fail, that you won't be able to plan out the clock. And then you ask them those 3 words back again. So it's a very quick test that you could do, let's say, on a loved one at home, sort of quietly just say, can you remember ball, cat, tree for me? Do the clock. And it's amazing some of the people that you find on this thing. Now, it works a lot better if you remember the same 3 words, of course, in terms of
What was that, red?
We found a few doctors this way as well. So.
All right, next question.
My only comment is ball, cat, tree.
Ball, cat, tree, right. Wendy Vandenbroek writes, can a doctor explain why B12 deficiency happens? You're hearing this a lot more now, B12. In fact, I just found out that I'm B12 deficient in my last annual. Why? And can you explain why it happens, Peter?
A couple of things is the amount of red meat that you eat. So therefore, we have a lot more vegetarians. And as people get older, what happens is that they eat less red meat as well. So therefore, their B12 levels might be lower for that. The other reason why we have it is that in families, it runs because you need an escort for your B12, something called intrinsic factor. So your stomach actually makes this, and it attaches to the B12, and then you can absorb it. So basically, if you're missing that, that's why in some families, you'll see that they're low in B12 as well. So it's your intake by diet as well as whether you're missing that particular intrinsic factor.
Right.
So, you know, a lot of people used to get injections for B12 deficiency, and we now know that virtually everyone who has B12 deficiency can be treated with just oral supplements, so, you know, B12 pills. And so that's been a real advance, actually, because, you know, even when I was training, we had a lot of seniors, for example, who would come in for B12 injections once a month. Turns out to be totally unnecessary. For almost everyone who's B12 deficient can be treated by mouth.
Let me try and do a couple here quickly before our break. Holly Sanders writes, why does the medical community still not have enough information on migraines and cluster headaches? Danielle, you try this one. They're two different things, but in the same kind of family.
Sure. I mean, these are two common kinds of headaches, and actually the most common kind of headache is tension headache. Sometimes they can be difficult to sort out. But I think there's this is one of the areas where increasingly online education is useful not only to physicians but to patients also. And so if people are experiencing headaches and they're finding that they're frustrated and having difficulty treating them, this is one of those circumstances where people can bring information into their provider and have a conversation about, do you think this truly was a migraine? Is it possible it could be something else?
All right. Evelyn Markin writes, when is it appropriate to ask for a CAT scan or an MRI scan? Peter.
Well, it's interesting. So basically, patients come in demanding they want to know what's going on. So therefore, our job is to figure out what test would be the best. And so the thought is that it may not be an MRI scan or a CAT scan, but they heard it on somewhere on television or they read about it. So usually what we do is we check out, is it something in the bone? Is it something in the joint? Is it something inside the belly? We use normal tests. Let's say ultrasound may be able to tell us all that we need to know about the gallbladder, for example. So when your doctor is using certain tests, they're thinking about what am I looking for and what will that test show me? Now, the ultrasound may not show perfect all of the results, so therefore sometimes we need a CAT scan, which does well going through bones and things like that, but an MRI is better for soft tissue. So can you bring it up? The answer is yes, but just don't be demanding about it, because I think your physician is sort of working through what is the best test to figure out what's wrong with you.
I think there's a false perception out there that MRIs are the best diagnostic test ever, and they're not for all conditions. So I agree with Peter. I think you can bring it up with your physician. They'll tell you why a certain test is indicated or not indicated.
And in many cases, they don't add any extra new information. So that's why we'll be very selective when we want to use them, especially in diagnosis around dementia.
Okay, time for that quick break, I promise. But when we come back, a key common question on cancer that worries us all. And welcome back to our national checkup and what we hope could become an annual event. Your questions for our doctors. Danielle Martin, Peter Lynn, Viv Rao, and Samir Sinha are all here tonight. And the first two questions, I kind of run them back to back here because they're somewhat similar. Preston Rutten writes, why does it take so long to see a doctor? And then Ellen Walker writes, why does it take so long to get a family doctor? Two rather common questions. And the answer, Danielle, is?
Well, on the family doctor front, there's good news, actually. So we have a huge number of new graduates from family medicine coming into the Canadian healthcare system now. And so the reason why it takes so long increasingly is not because there's a shortage of family doctors, but because either we're not getting to them to the right places where they're needed, or because people just don't know how to go about finding them. So several provinces have now put in place programs to help people who don't have a family doctor find one. In Ontario, there's one called Healthcare Connect. In BC, there's one called a GP for Me. They're online, you can sign up. And it's a way of trying to coordinate things, which really links to the specialty question as well. You know, why do we wait times to see specialists? Sometimes it's because we don't have enough resources, but often it's because we don't organize those resources very well. So the concept of what's called centralized intake, where you have a single line up instead of different wait times for different specialists has been very effective where it's been used. And so the question is, how can we apply that approach in other specialty areas?
All right. Well, I think that's going to sum up everybody's answer for that. Let me move to the next one. It comes in by video from Vancouver from Jenny Simpson.
As a 36-year-old adult, what can I do to prevent cancer? And what can others do? I mean, how genetic is cancer? And how much can we actually control? Thank you.
All right. Well, that too, a relatively common question. Peter, what's the answer?
Yeah, we can't pick our parents, so therefore our genetics are with us. So we can find some of the new genetic markers, like BRCA, breast cancer marker. So if you have that, you can't repair your DNA very well. So that's why we need to make sure that you get rid of any damage that might come. So I often give my patient this example. Let's say you're born with fair skin. You go out in the sun, you get burned, you have higher skin cancer risk. So if we can reduce the burn, then we can reduce all of those other risks along the way. So what you're dealt with and what you're going to end up with are different. What we have to do is reduce the risks that we're exposing you to. So less alcohol, less smoking, less obesity, all of those things will help reduce your cancer risk regardless of what you were dealt with in terms of your genes.
Samir?
Again, the best thing is, beyond, as Peter was saying, if you can't change your family history, the one things you can do is modify those risk factors. So we always say, and we can't say it enough, is regular exercise whenever possible. Things like just taking a walk 3 times a week, no smoking, taking things in moderation like alcohol, and just being mindful of what we eat and trying to make more healthier choices. Those are all good things that we know can simply reduce our risk of getting cancer.
Viv?
Yeah, I see it all the time. My grandfather died of a heart attack at 50. My father went to 51. I'm 52. What should I do? Stop smoking. So yeah, you can't change what you're dealt with, as Peter said. But when you know you're at risk for certain diseases, do whatever you can that's modifiable to prevent you from getting that disease.
All right. Thank you all. Good discussions. Good answers. Thank you as well. This was a test idea. Let us know what you thought. You can reach us at cbcnews.ca/thenational.